Please.
Hello. I'd first like to thank the organisers for inviting me to participate in this symposium, with the title of my talk being The Prediction of Success of Sleep Apnea Treatment. My disclosures are that I'm a director of a not-for-profit educational company called APOS that receives sponsorship from a number of medical device companies, including Olympus, Medtronic, Smith & Nephew and Spire Medical, all of which are probably relevant to this talk. Now, I'm sorry I'm here virtually rather than in person. As you can see, it's a long way from Adelaide. I'm really sorry I can't be there with you, but I hope to join you in St. Petersburg next year. So what is success following sleep apnea treatment? Is it just reduction of the AHI? Now that's what the sleep physicians would like us to believe. But in fact, we're now increasingly aware there's a lot more to sleep than simply the AHI. And as we all know as surgeons, we can improve other parameters of sleep far better than we can actually improve the AHI. And I think we do need to look at patient quality of life measures, ESS and other objective measures of sleep as well when calculating just how much benefit we're giving patients. And I think we can do better. It's certainly going to be interesting to see how the goalposts move as we move through in this debate over the next few years. Because as we all know, the respiratory physicians haven't kept the goalposts in the same place. The definition of what is an apnea and a hypopnea has changed several times over the last few years. And as we also know, that our patients will tell us after they've been in for a sleep study that it really was an abysmal night's sleep. So how do we report results? Well, the answer is it all depends on how you recorded the sleep study in the first place. And this was a paper we published in Laryngoscope a few years ago, looking at a series of outcome data from our centre, looking at patients undergoing multi-level surgery. And depending on which criteria for measuring an apnea or hypopnea, both the pre-op and the post-op AHI changed quite significantly. And whilst there's a lot of evidence for severe sleep apnea being a predictor of severe cardiovascular mortality and morbidity, the evidence for mild sleep apnea just isn't there, and moderate sleep apnea is controversial at best. So if we just want to get patients out of the severe category, and you can see here, if we use the AHI Chicago method of analysing the sleep studies and regard success as having an RDI of less than 20 and reduced by 50%, which the FDA would like us to believe, we're looking at less than 39% success. But if we're just trying to get patients out of that severe cardiovascular mortality group and use the AHI recommended criteria, you can actually, with the same group of patients, have a success rate of 92%. So the big question the sleep physicians always ask us is, how good is surgery? Now this is a rhinology meeting, and nasal surgery is something we'll often do in a way to either facilitate CPAP or even try and resolve snoring or improve sleep apnea. Now, Stacey Ishman and her group did a meta-analysis looking at patients with nasal obstruction and sleep apnea. And they looked at a large group of research studies and concluded that essentially the AHI didn't change much whatsoever, but the Epworth Sleepiness Scale was improved quite significantly. And that is because nasal surgery improves sleep fragmentation, which means that the whole physiology of the sleep pattern is improved really quite significantly. And that means we have a deeper, a better sleep, and we're less tired during the day. And if patients are less tired, irrespective of what the AHI is, they generally feel a lot better. Now, another meta-analysis looked at a much larger group of patients undergoing nasal surgery. And you can see here a much more significant group of patients was studied. And you can see here for AHI, we can lower it, but only by about 4 points. And this was looking at 17 different trials. However, when we look at ESS, likewise, we're reducing ESS by 4 points. Now, that's a much more significant improvement. So you can move a tired patient into a non-tired patient category, and really that is going to improve their quality of life and improve their ability to function, less chance of motor vehicle accidents, etc., etc. Now, Robson Capasso and a lot of collaborators looked at systematic reviews in sleep apnea a few years ago, and really the results haven't really changed much. And what they found was that depending on the review you looked at, how you define success following surgery varies really quite considerably. When you're looking at largely palatal surgery, which was single level, the series evaluated success between 13 and 55%. And I think this wide range maybe goes back to my previous slides looking at how do we define AHIs at Chicago, recommended alternate, and what is the definition of success. When patients require phase 2 procedures, you get 43 to 86%, and multiple stage procedures, which probably is the same as the group above, and you can see the percentages are pretty similar, 40 to 78% success. Mandibulomaxillary expansion, as you'd expect, actually carries the best success of the whole lot, but of course you have to choose your patients carefully, and not many patients are willing to undergo this as a first stage procedure. Now, our group undertook the first multi-level randomized controlled trial looking at patients who'd failed CPAP or were non-compliant, and the protocol was published in Sleep at the end of 2019. And the final paper was published in JAMA last year. And this group really was a very tightly coordinated group. From out of over 600 patients assessed, only 102 were randomized, but we actually got by far the vast majority of these patients through. And the final study data showed that we actually improved the patient's AHI quite significantly, from 48 down to just over 20. It would be nice if we got them under 20, but due to one very unfortunate outlier that stuffed up our data. But if you look at the improvement in ESS, 12.4 to 5.3, and really that was a very dramatic improvement. And this was a slide that basically summarizes all the different patient outcomes. On the left, in orange, the surgery group, the blue, the medical management on the right. And when you look at AHI, we reduced them by 27.1. ESS minus 7.1. Now, the problem with doing an RCT is you've also got to look at the control group. And the patients who had no surgery also improved their AHI by almost 10 points. So that really stuffed up our comparison of surgery from minus 27.1 down to a less favourable advantage over control, but nevertheless quite significant. And all the other sleep study parameters, with the possible exception of blood pressure and the patient's response time, which is another measure of fatigue, were highly significant. Now, this was just using coblation tongue channeling, which stiffens the tongue. If you resect a large amount of the tongue by using a robot, you would actually expect we'd get much better results. And this is a quick video, and I'm going to skip through this in the interest of time, using the med robotics to actually excise most of the lingual tonsils and really get down to muscle. And removing a massive amount of tissue from the base of the tongue. And naturally you'd expect that this is just going to be so much better than just using a few coblation channels. SAM's trial, where we just when you look at all the meta-analysis, the AHI improves by about 24.25. So that's actually less than in SAM's trial, where we just did a modified UPPP variant and coblation channeling of the tongue. And the ESS really was actually less significant than SAM's trial. When we look at hypoglossal nerve stimulation, this is the new kid on the block, of course, and there may only be certain groups of patients for which this is appropriate, but 5-year outcomes do look extremely attractive, and this is Tucker Woodson's paper showing that the benefit from hypoglossal nerve stimulation does seem to be long-standing and maintained over a period of time. So why is it that some patients do extremely well following multi-level sleep surgery and others do less well. And likewise, why do some patients who are highly selected do really well after hypoglossal nerve stimulation, whereas others, again, don't gain the same benefit? And I think we're now aware that sleep apnea is not just all about a blocked tube, and there are various sleep phenotypes, and as surgeons we're probably not very good at looking into the various different phenotypes of our patients. All we're concerned on is where is the blockage in the tube and how can we fix it by chopping bits out or repositioning them. Now, we know anatomy is important, and it's important to a greater or lesser degree in all patients with sleep apnea. But there are other phenotypes which come into the equation. Patients can have ineffective dilator muscles, and that's about a third. We can have patients where their ventilatory control and their response to obstruction is variable, and that's what we call loop gain. Or patients where their respiratory arousal threshold is low, and therefore they wake up more frequently in response to minimal obstruction of the airway. And there are various different treatments for each type of phenotype. Now, there we are at the top, upper airway surgery for a compromised airway. Hypoglossal nerve stimulation probably works on the cohort in the bottom left with the floppy muscles, but there are drugs, and also upper airway muscle training is now very trendy, which also probably provides a bit of benefit. So I think if we were able to phenotype our patients better, we might be able to pick our winners better. And by actually looking at how easily the airway collapses, we can determine how much impaired anatomy there actually is. And this is looking at upper airway collapsibility, and you can see that the green triangles on the left are in a patient with very mild anatomical compromise, and therefore their airway collapses at a -4 centimetres of water, whereas the patient on the right with severe sleep apnea and severe anatomical compromise actually collapses at a positive pressure of 4.8. So that patient's going to obstruct very, very easily from their severe anatomical compromise. And with loop gain, the patient on the top has low loop gain, so you obstruct the airway, and the patient then stops breathing, as you can see by the reduced amplitude. But then when the obstruction is relieved, they come back to normal fairly quickly. In the patient with high loop gain, after an obstruction, their breathing goes crazy, they get hyperventilation, which of course blows off CO2 and completely messes up the whole regulatory system, and therefore they're much more likely to have disturbed sleep. Now, Danny Eckert, who's our new professor of sleep medicine at Flinders, has designed the PALM scale, which categorises patients to anatomy, respiratory arousal, loop gain or muscle responsiveness. And here's a cohort of patients with a Venn diagram looking at the different categories. And you've got PALM 1, PALM 2 and PALM 3. And PALM 2 is the much larger group and can actually be subdivided still further depending on the degree of anatomical compromise that exists. So how can we actually apply these phenotypes and look at them and determine surgical success? Well, a group from Monash in Melbourne looked at this and found that patients with high loop gain actually didn't do as well following multi-level surgery. And all patients, 12 out of their cohort with a high loop gain greater than 0.5 were surgical failures, whereas the majority that came in under 0.4 were successes. And loop gain can be measured relatively easily from a simple PSG tracing. Are there other ways we can detect sleep phenotypes? Well, yes, there are. And using machine learning, what we can do is actually look at a PSG recording and actually use the machine to see if it can categorise what sort of phenotype the patient has. And I think with the right algorithms, a lot of tertiary referral sleep labs should be able to do research like this for your sleep patients in the future. Upper airway collapsibility is related to the critical closing pressure during sleep, and we can actually measure that by putting in both posterior choanal and epiglottic catheters and doing negative pressures during the awake phase. You can put in intramuscular electrodes into the tongue, into the genioglossus, relatively pain-free, and actually work out what the P-crit is quite easily. And you can see here as a patient with a negative pressure bag being placed over their face and obstructing their airway. And the trace on the left is a patient with very high collapsibility, the patient on the right, low collapsibility. And if they're collapsing relatively easily, then they're more likely to do well following multi-level sleep surgery. Now, although we might think that increased airway collapsibility will improve surgical outcomes, we need to do a research trial to test that hypothesis, and that's certainly something we're working on in the future. There's been a lot of work on detecting site of collapse, and we all know that DICE is highly controversial. It's non-physiological, it's very easy to lose the airway in a sedated patient because they don't naturally wake up and start breathing again. And there's some work being done out of a group in Boston who actually looked at airflow tracing, and we're actually able to detect epiglottic collapse, retrolingual collapse and palatal collapse in a very high degree of predictability. In a way to try and make this a bit easier, we've tried to develop a fibre optic video catheter where we can do pharyngeal manometry and also have a little micro camera placed in the postnasal space and actually analyse what's happening during sleep. You can see here, this is actually a patient just doing a Muller manoeuvre, but you can see the video image we're getting from this catheter, manometry catheter, during snoring is actually really quite good. And we were able to detect both retropalatal and retrolingual collapse. Now, we've had a slight glitch with the development of this catheter, but we're hoping we'll be able to develop it still further over the next few years and actually start doing some studies in patients while they're asleep. So, in conclusion, multi-level sleep surgery can, on average, probably reduce the AHI by about 25 points, but other things such as oxygen saturation and Epworth Sleepiness Score improve much more. However, control patients will also improve, which probably means that these results are not as good as we like to think we are. Anatomical compromise is present in all patients, and we can now measure this by using simple airway collapsibility techniques. These phenotypes do affect the outcomes of sleep surgery, but more research needs to be done as to exactly how and the magnitude of these changes. But by just simply looking at polysomnograms, in a lot of patients, we can probably identify these phenotypes far easily than we might think. And new technologies such as video manometry hopefully will be available in the next few years, which will allow us to phenotype these patients much better and predict which patients are going to do well with surgery, but more importantly, who should not be offered surgery in the first place. Because as we all know, they're the patients that come back to haunt you like the proverbial albatross. So I'm sorry I can't be with you. This is South Australia, nice sandy beach like Greece, but please enjoy the rest of the conference and I look forward to seeing you all soon. Thank you very much.